ladies and gents, and welcome back to the A to Z of the NHS. You're joining myself, Dr. James Gill, and one of the big dogs, Dr. Andy Stein, one of our renal consultants. And today we are going to carry on with the letter E. So Andy, what have you brought us on the E side of things today?
Today's topic is going to be epilepsy, and I thought we'd talk about it because A, it's very common, and B, we're reminded about it on a daily basis on the news.
Okay, so I suppose that suggests that certainly the TV you're watching is a little bit more exciting than mine perhaps, but okay. So we're going to do epilepsy, and we're going to follow with the setup that we had in the previous videos. We're going to do a fact versus fiction, we're going to dispel a myth, and also we're going to talk about something the doctor doesn't tell you when it comes to epilepsy. So what are the three that we're going to be looking at there?
So in terms of fact or fiction, I thought we would debate whether flashing lights really precipitate epilepsy or a single seizure or not.
Oh, are you a Pokemon fan as well, Andy?
Pokemon? What's that? Is that a form of sport, or what is that?
Well, in that case, we'll see how Pokemon connects to epilepsy shortly.
I think for dispelling myths, we will debate whether having one seizure stops you from driving or not. In terms of what the doctor doesn't tell you, I thought we would debate whether one fit makes you an epileptic or not, and also I'm going to talk more about tics and adverbs and why doctors don't do adverbs.
Right, if that sounds interesting to yourselves, join us as we carry on to discuss epilepsy. Starts off, let's just give a quick run through for those at home. Refresh my memory, because I'm only a simple GP. What's epilepsy?
Epilepsy is a very common condition affecting 1 to 2% of the population. To put that in perspective, diabetes is about 2 to 5%, so it's one of the commoner chronic conditions. That means that with a population of about 65 million, approximately half to 1 million people in this country have epilepsy. If you add all types of epilepsy, seizures and fits, in fact it means 10% of the population will have a fit at some point in their lives.
That's actually a really good number. So I'm very lucky that I still have close connections with the guys I was at university with. Not medical school, but from my first degree. And there's about 10 of us.
Got a degree?
I know, amazingly.
You never told me that.
I've also got a master's as well.
You never told me that either. I assumed you were an imposter. Anyway, on with the show.
I'm very lucky that I was. I've still got close connections with 10 of the people I was at did my first degree in Nottingham with, and I don't think one of them will mind, but one of them has had a seizure. And he doesn't have a diagnosis of epilepsy, but he has had that seizure, which has caused significant issues for him in terms of driving, particularly because he's from Wales, and in the rural parts of Wales you really do need a car over there to get around. So that number is actually quite accurate in my personal experience, not even just as a medic.
What is epilepsy? Epilepsy is a condition, usually chronic. It can be acute, in other words, you can have it over a short period and never again. It's characterized by sudden bursts of electrical activity that lead to seizures, or as they're sometimes called, fits or epileptic fits. That's what epilepsy is.
So you've said about epilepsy there. What's a seizure then?
The medical event leading from epilepsy. So epilepsy, if you like, is a syndrome of which there are many causes, which we'll talk about later, characterized by these events called seizures or fits. I thought we'd talk a bit more about the various types of epilepsy. Is that relevant to you in general practice?
I think so, because when I'm dealing with the lifestyle side of things, it doesn't matter whether or not the patient has had a grand mal. So that's the classic seizure that people sort of have from TV, the person shaking. It doesn't matter whether it's a grand mal or whether or not it's an absent seizure. They're just, not, the person's gone vacant, they're not there anymore. These still have that same repercussions in terms of their lifestyle. So absolutely.
Okay, so there are various types of epilepsy. What I'm about to tell you is largely taken from when I was at medical school a long time ago. But interestingly, most textbooks are now going back to these older classifications, and the type of epilepsy that most people have heard of is the one that you just mentioned, which is grand mal epilepsy. This is the tonic-clonic seizure, which you think of as classical epilepsy that you see on the television or in videos or whatever, where the patient shakes, their whole body is shaking, they become unconscious, they bite their tongue, they froth at the mouth, and after it they're in a post-epileptic state where they are drowsy and confused for a while. They may or may not have an aura. That's the feeling that they're about to have a grand mal fit, and this is the type of epilepsy that most of us consider, if you like, true or classical epilepsy.
Now, I find that aura, the sense that something's going to happen, absolutely fascinating, in the sense that we can't fully explain what it is yet. However, we can train a dog to detect it early so that they can actually tell the patient, you're going to, well, Lassie pops up, hey, you're going to have a seizure. So the patient can sit down on the floor so that they're less likely to have that seizure, in a way that could injure themselves. Yet we've not got that thing yet. But I think this is the wonderful thing about medicine, how there's so many things we don't fully understand yet. I mean, one of your colleagues at UHCW, Prof. Weikart, who is probably one of the most intelligent people I know, have you seen the stuff that he did with Professor Arasaradnam about creating an electronic nose?
No, I haven't.
Absolutely amazing, about smelling cancers in urine and things like that. And
wow.
Personally, I think that, given that dogs are known for their sense of smell, I wonder whether or not the electronic nose could be pivoted to have, to create perhaps something, a handheld device that could be worn maybe for detection of epilepsies.
I must admit, I don't know much about dogs and sniffing and what dogs can do, but I do know from friends who have dogs that they say they can tell whether their owner is ill or not, and even where the illness is. So I'm willing to believe that. So it's a disease of which there are various types. We've talked about grand mal epilepsy. There is another type called petit mal. There are other phrases like simple and complex partial seizures. There are absences, and there are other rarer types of epilepsy. I don't think we'll go through them all today. The key thing is the latter group that I've described don't always involve a complete loss of consciousness, which grand mal seizures are linked to.
Well, we've got a good summation there about what epilepsy is. So let's go to our three questions. So shall we try and dispel a fact versus fiction here?
Okay, so when you watch the news or some television programs, there's often a warning about flashing lights, and either they say directly that this could lead to epilepsy, or there's an implication that it might. So they tell the entire world to turn away from the flashing lights that are about to appear. And is this true or not? Is this sensible or not? So is it true or not? Well, the short answer, yes, it is true. There is a subset of people, mainly with grand mal epilepsy, who have a form called photosensitive epilepsy. In other words, flashing lights or things like flashing lights, in other words, where there's a rapidly alternating image, such as an overhead fan or the sight of an emergency vehicle, or a fluorescent bulb on the brink, or the television itself precipitating an epileptic fit or a series of fits. So there is this subgroup of people for which this happens.
Because it's actually specifically the change in luminance from the bright to dark, and those same people could actually be affected by simply a static picture of bars and lights and blacks. Lights and blacks could do it as well. Although it is rarer, but it's still the same pathway that gets affected, we think.
I must admit, I didn't know that. I do know that this subset of people with photosensitive epilepsy are very grateful for these warnings. They're also taught to be careful by not watching television in a dark room, for example, not watching television or a video very close up. However, and you can tell viewers whenever I do a however, I'm not so sure whether we really should be having these warnings to us every day, every evening, every night, every time we turn the television on. What do you think, James?
Well, to be fair, I don't recall when I last saw them, so I'm not sure they're that frequent. But do you know where that...
He's such a cyber nut, he doesn't have a television, but don't tell anybody.
Do you know where the the biggest episode of seizures came from?
No, I don't, but I've got a feeling you're going to tell me.
Yeah, I've been on the edge of my seat with this. I've got a Pokemon thing for you. So Pokemon is Japanese for pocket monster. In 1997, there was an episode of Pokemon, this cartoon show, which was shown in Japan. And there was a series of flashing lights in it that hit that sort of specific frequency. Off the top of my head, I think it's about 20 hertz, so 20 cycles per second. I could be wrong on that though. And that caused a large number of children, I think there are about 300 children, had seizures directly as a result of this TV show. And that's one of the points that the sort of the watersheds were, hold on, we need to make sure that when there is this going forwards, we warn people about it. And it can happen with computer games as well. Anything sort of rapidly firing like that. But the warnings on computer games are less accurate. The reason why I say accurate is we've got a piece of software that we can put a movie or a TV show or a news clip through, and it'll give a warning. Hold on, there's the risk of seizure with what's going on here. Hence, we'll get the warning. However, because you can play a computer game from so many different angles and things like that, I mean, you choose how you're going to go through the dungeon, etc. in FPS. You can't guarantee how the flaming torch on a wall will be seen by everybody. So the warnings on a computer game are less accurate than they are for TV. If it's on TV or movie, it tends to mean that the computer algorithm has said, hold on, we've seen flashing lights at a high enough frequency here.
That's very interesting. I must admit, I have no idea what he's talking about. All I know is that these Pokemon-y thingies and Xboxy thingies are a load of unwanted, crazy hurly-burly.
Warning, old man rants at sky.
I think we should discuss now, just because something can happen, whether we should warn the public about everything, all the dangers of everything in life. So, for example, James, why, when we're about to watch the news and the weather is a bit cold and icy, which it often is in our lovely country, does the BBC not warn the elderly not to go out, and if they go out, to wear sensible Clark's shoes? I just raise this point, viewers, because I think there is a counter argument whereby one can warn the public about so many risks, so many problems, so many things that might happen. We can be paralysed with fear and not go out at all. It's a bit like negative signage. If you tell people not to spit, they may feel like spitting even if they didn't start the day thinking they wanted to spit. And I think that warning people about risks in society develop a fear and anti-culture that may not be mentally healthy.
I'm not sure I'd agree with that necessarily. I'm not sure that someone sees a danger of seizure sign and says, right, I'm going to have one just to annoy the sign. However, I do think that generally we can probably overwarn people, and as a result of that, you stop paying attention to the warnings generally.
I think we're going to move on now and talk about dispelling myths. Is that right? Mm-hmm. The myth we're going to talk about is whether having one seizure causes you to lose your driving license or not. Is that a problem for you in general practice, James?
It's one of the biggest fears for patients when they have a seizure or that label of epilepsy. Hold on, am I no longer going to be able to drive? That's my livelihood done, my life's over, because part of our modern world requires the ability to get from A to B, normally when somebody desires it. So public transport can still be used, but it is very difficult. So I think that's a big issue, yes.
But Is it because it's a big issue, or is there any other reason? I've heard that GPs now often don't investigate and treat epilepsy themselves. They send patients to a brain doctor called a neurologist in a hospital. Is that right?
I wouldn't describe it as quite that I'm batting the work away, but we have a pathway of anybody that's had that first seizure. We put them into the first seizure clinic. Now the reason being is largely it's twofold. One, how big an impact is this going to have on the patient's life, as in can they drive, can they go swimming and things, and how big a medical issue is this going to be? So, have you had your what's the cause of your seizure? We can have a provoked seizure, such as an unwarranted episode of Pokemon. There we say, right, we know what caused it, this may happen again, so we have to be extra cautious with that person. However, we may have an unprovoked seizure, where we've got no idea where and why it's come from. In that patient, we want to be so much more cautious because we don't know what gave rise to it. Now, the unprovoked seizure is the problem for us generally, because we just don't have an answer for it. What caused it? When's it going to happen again? Will it ever happen again? So many unknowns, so we put more restrictions on that patient. Conversely, one of the other things with that first seizure clinic, finding out the cause of it, we may find something much more troubling than the seizure in itself. So, for example, you could have a seizure because of a brain tumour, and the first evidence of that brain tumour is the seizure, and that's why we put them into the first seizure clinic, because we have those excellent consultants that have got access to all the big toys, so they can quickly streamline patients, so we can have as minimal impact, and that minimal impact still may be 6 months of not driving on their life, versus actually we've found other things, we can quickly get them into the system, perhaps to deal with a brain tumour or something like that.
That's a bit worrying about brain tumours. Are brain tumours common? Are they a common cause of epilepsy?
Thankfully they're not, and the commonest cause of epilepsy is that, or the commonest cause of a seizure, should I say, is that unprovoked one where we don't know why it happened, but thankfully it never happens again for that patient.
James is right on that. It's about 1/3, 2/3. So 1/3 of patients have what we call an unprovoked seizure, or idiopathic or unknown epilepsy, where there's no underlying cause, and that may or may not go on to a chronic condition in which they have more. And about 2/3 of the mixed bag of other causes, including strokes, head injury, metabolic causes like diabetes, brain tumours. In terms of brain tumours, it's important to realise that they're not all cancer. You get benign brain tumours, and some of the cancerous ones are not as serious as others. So it's important not to go from this video thinking that everybody with epilepsy has a brain tumour and that's serious. That's absolutely not true.
You say that you have benign brain tumours as well. One of my bosses, one of the senior GPs, for years she had a benign brain tumour and she called it Dory.
Dory?
But I think that was how she'd dealt with it.
There must be something about doctors and benign brain tumours. I know of another doctor who presented with epilepsy and was found to have a rare disease called acoustic neuroma. You can look that one up, viewers, which was entirely treatable, and when it was removed, he was fine. Okay, so what I'd like to do now is just talk a bit about the investigation of epilepsy. So what happens when James sends a patient to the hospital to these first fit clinics. What do you think happens to them, James? What tests do you think they have?
Well, I imagine it's going to be, because we've got the possibility of an unknown seizure, it's going to be a full top-to-tail workup. So the bloods to look, as you said, the metabolics, the scans to make sure we can't find a cause of it, and that crucial one that I don't know quite so much about, the EEG, where we're going to look at the electrical trace of the brain?
Absolutely right. So those are the tests we do, basic blood tests, imaging such as a chest x-ray, a CT of the head, or even an MRI of the head, which is, if you like, a super CT, and this funny test called an EEG, which you have electrodes put on your head, and the electrical activity inside the head is measured, and you get loads of wiggly lines.
Now, I think most people would follow along, right, we're getting head this, head that, head that. Why would they do a chest x-ray?
Chest x-ray really is just part of the workup of many long-term diseases. There can be things on it that you didn't predict, or there may be a second diagnosis that may be relevant. But the real reason for doing a chest x-ray is if there is a tumour in the brain, is it a primary tumour? In other words, has it arisen in the brain, or has it spread from somewhere? And in both men and women, particularly those who have smoked, brain tumours often come from a lung cancer, and that's why we do a chest x-ray. And in women, of course, breast cancer, which can spread to the brain as well. So that's the reason why we do a chest x-ray. Talking about breast cancer, it's very important to realise that the history there, the questions we ask a patient in the examination are just or as more important in epilepsy than the investigations. Everybody forgets to examine the breast, for example. That's a very important thing to do, but it's important to do a full general examination and not just a neurological examination. And part of the reason for that is, as we said earlier, about in a third of patients, investigations revealed nothing. In other words, the patient has idiopathic or an unknown cause of epilepsy. And also because we know that the EEG actually isn't that useful. It's only abnormal in about 10% of patients with epilepsy. And also the other way around, you can have an abnormal EEG and have a normal brain and no epilepsy. So it's not a great investigation, really.
And just to link back to our previous topics, if you want to click up here, you can go to our breast cancer discussion, although it's not quite as slick as the chats we're doing now.
Shall we move on to the third bit of our talk today, our discussion today, and that's about what doctors don't tell you?
Yes, and I think I'll start off this a little bit because I used to come across this particular aspect when I was in the A&E department. So we've talked all about seizures at the moment and the first seizure clinic and all the associated problems with that. But we're all allowed one seizure. It's not the end of the world to have that single seizure. And that's what, as doctors, we don't tell people a lot. And I think the reason being is that one of the commonest causes, particularly in children, is that febrile seizure. So often in the A&E department, I would have a child come to me with the parents who they've got a temperature of 40, 41 degrees Celsius and they'd had a seizure at home. Heck, even one of my good friends, he brought, as an A&E nurse, he brought his child in having a febrile seizure. And I think that for me was a great exercise in knowledge control, because on the one side he's there as a parent with his fitting child, but on the other side he has dealt with parents of fitting children at length. And I must confess, I was astonished with the level of calm and reassurance that he had for himself and his child with that one.
Well, funnily enough, a similar thing has happened to me and my family. My daughter, when she was a lot younger, had a friend who had a single seizure following a fever, what we call a febrile convulsion, as James says, and nobody anywhere labelled her with the words epilepsy or epileptic, and neither did I, and I was able to reassure the family that I didn't think this was going to be a long-term problem, and it hasn't been. Anyway, back to what doctors don't tell you, my little phrase for it is that we are all allowed a free fit, and that's because deep down we all have epilepsy. We are all epileptics, because what epilepsy is a syndrome, a group of diseases that can have a cause or may not have a cause, but deeper than that, what it is a way that the brain reacts when it's under stress or a combination of stresses. So I could develop epilepsy today, and so could you, viewers, but it is relatively rare, though 2 to 5% of the population maybe is not that rare. So it's not something I spend a lot of my life worrying about, and I wouldn't suggest that you should either.
So I think what you're saying there is that we all have the potential to have a seizure. We all have the potential to potentially develop epilepsy, but our bodies have systems to ground out excess activity so it never actually happens and manifests. Would that be?
Absolutely, that's really a nice summary. And finally, I'd like to discuss adverbs. I have a particular dislike of adverbs. I have a dislike of them within medicine because I find them judgmental. In other words, if you label somebody with the adverb epileptic or asthmatic or diabetic, it conjures up a mental picture of what that person might be like. So some people might think that somebody with epilepsy is less intelligent, and if they're less intelligent, they're less able, and therefore you may not give them the job, or it may conjure up a picture of learning difficulties, or it may conjure up a picture of something else that is clearly not true. So I think it's very important as health professionals that we choose our words carefully and don't do adverbs.
Actually, I would agree with that completely. I think the one tweak that I'd have with it is Mrs. Jones has epilepsy, absolutely. But I think that in broad context, we can talk about epileptics in the abstract, just simply for use of language. But I agree completely, we should not be labelling people as you are this thing. It's not you, you're a person that has this problem.
Agreed. And so working on that, Mr. Smith could have diabetes, but we could talk about diabetics in the abstract in some form of technical conversation or a presentation like this, but not describe Mr. Smith as a diabetic man or a diabetic engineer or whatever, because it is, as I say, judgmental and creates unusual images in the brain about them.
Well, it's not only that, it's the way that, so in GP land, one of the things that we ask is that you give a quick summary to the receptionist so they can say what is they want to talk to their doctor about, and that means that I can prime my brain beforehand. And if I've got a patient that's got, they said low mood, right, I know I'm going to go down this route. And if I say, foot hurts, right, I know I'm going to go down this route. However, if we've got, diabetic review, then that can prejudice almost, because you create the diabetic image rather than Mrs. Jones with diabetes. So I think it's really interesting how we have to work with these phrases, but we also need to be very careful about how we allow them to control us as clinicians, and make sure we're very careful about not allowing that to result in prejudiced decision making. Actually, we talk about diabetics there, but one of the things that we worry about with patients with diabetes is that they potentially could have too much insulin and they could go hypo. They could have low blood sugar, and as a result of going hypo, you can cause a hypoglycemic seizure. But this is where I think it kind of links to that we're allowed a free seizure, because we can use seizures. In psychiatry, we can induce a seizure by giving somebody insulin. Someone who doesn't have diabetes, we'll give them insulin to produce a hypoglycemic seizure in the hopes of improving treatment-resistant depression. And we don't do it very often, but the patients that have had it do say, actually, this has been a life-changing event for me, because it sort of resets things. But that's done in a very careful, very controlled environment.
That's really interesting. I didn't know that.
And it's like the electric shock convulsive therapy, where again we induce a seizure by putting electric currents through the brain. And at medical school, I thought the concept of electric shock therapy was barbaric, and I will use that word, and that was because I was prejudiced, probably because one flew over the cuckoo's nest. And I thought, gosh, how could somebody do this? This is terrible. And I do not have that opinion now for two reasons. One, I have seen the shock therapies performed, and the patients have said that, they had not, the patients that I've seen that has had electric shock convulsive therapy said it completely changed their life because nothing worked for them. The counselling didn't work, the medications didn't work, and they were battling with thoughts about wanting to kill themselves. We essentially reset the patient, and they still have, mental health problems, but they don't have the same horrendous urges that they did. But that's in the abstract. That is in, patients that I have seen, touch base with, and then life has continued. My granddad, my personal hero, one of the best people I ever knew, had electric shock therapy for treatment-resistant depression. And I would have never known that he had had those sorts of mental health problems unless someone told me.
So what I think James is saying is, from the undiscovered country from whose bourne no man has returned, he has now described some scenarios where men have returned.
And I think on that point, we'll leave the Shakespeare and the epilepsy be. So thank you very much for joining us. I hope that you found this useful, stimulating and interesting, and we'll see you in the next one. Thank you. Take care.
Bye-bye.